So again, I'm going to try to just go over very quickly what I call avoiding the unexpected. And as I said, I'm not really a cataract surgeon, I'm cornea and refractive, but when you compare cataract surgery to refractive surgery, there are a number of differences. When you do a subjective refraction for cataract surgery, you're really only doing it for best corrected vision. You do an objective measurement, and that can be an autorefractor, IOL master, you can hear about the Pentacam AXL, but you do a tomographic evaluation, and that is, again, similar for refractive surgery. You want to rule out occult disease. You want to examine for irregular astigmatism, but more so, it's important here to determine the source of the astigmatism, and that's very different than what we need to do for refractive surgery. And why is that? And again, why is it important to screen out for abnormalities, particularly occult keratoconus? And that's because premium lenses, multifocals, EDF lenses, are relatively contraindicated in patients with abnormal multifocality. So you do want to look for acute, occult, or subclinical keratoconus. And again, you can see that. I'll show you a better picture of it. But this is an example of a patient that would be completely asymptomatic, excellent visual acuity, but has subclinical keratoconus. And this is a relative contraindication for a premium lens, again, multifocal or EDF. Now, screening with anterior-based systems, an example, again, any Placido system, an IOL master, is really inadequate, particularly now that we've gone to toric lenses and premium lenses. We have greater expectations of the patient, and they really require greater preoperative screening. Now, many of you, if you're doing refractive surgery, are familiar with the Belin ambrosia or the BAD display. It has utilization as a rapid screening tool for your cataract patients. It's an excellent rapid screening tool to identify patients who stray from normality. People kind of think it diagnoses keratoconus. It's really designed as a screening tool to separate normal from abnormal. The final D does not diagnose keratoconus, but shows variance from a normal population. Now, as opposed to refractive surgery, with most of our patients are younger and, quote, normal without pathology, in the cataract population, we're dealing with an older population. So compared to the refractive surgery patients, we should expect a higher final D values. But any final D greater than 2.6 should always be of major concern. So again, the BAD display is an excellent rapid screening display just to separate your patients from normal and abnormal. I'm just showing this, not going to discuss it, but I'll show you 3 quick slides. For those interested, I'll be talking tomorrow at the Oculus booth at 11 o'clock. We do have a new keratoconus staging and progression display. The staging or classification is called the ABCD staging. And you can see it, this is what the classification is based on. I won't have time here to discuss it, but those who are interested, again, can come tomorrow, Sunday, to the Oculus booth at 11 o'clock. So going back to cataract surgery evaluation, realize again that both the subjective and objective refractions measure the total optical system. So that's anterior cornea, posterior cornea, and lens. And since the lens is removed, we need a way to measure really only the corneal component. And as I alluded to before, keratometry, video keratoscopy, the IOL master only measure the anterior component. So we look at total corneal refractive power. And total corneal refractive power incorporates both the anterior and posterior cornea and lens thickness using ray tracing to produce what is really the total refractive power of the cornea. Now, this is particularly important in toric IOL surgery, where the goal, if you ask people what's the goal of your toric IOL surgery, some people will say to totally correct all the cylinder at the exact axis. Well, that may be the ultimate goal, but it's really not a realistic expectation. The realistic goal is to minimize the residual astigmatism without overcorrecting. You really want to avoid overcorrecting, because if you overcorrect a patient, you flip axis, and that's often not very well tolerated by the patient. Now, most toric IOL formulas attempt to compensate for not measuring the posterior corneal surface. And that's true with the original. In the US, the Alcon is probably the most commonly used toric IOL. The original Alcon formula just assumed the constant relationship between the anterior and posterior surface. The newer Barrett-derived, people think measures the posterior surface. It does not. It does a better job by not assuming a constant relationship, but still makes assumptions about the posterior surface. And there's been a number of papers now that will show you that SIMK values, again, just taken from the anterior surface, overcorrect with the rule, and SIMK values tend to undercorrect with against the rule. The biggest thing I always tell my residents when I'm proctoring them for their cataract surgery is regardless of what formula you use, they cannot compensate for the axis change. And we'll go over that later. So the picture on your right is the original Alcon Toric IOL. And I routinely have, in addition to the bad display for rapid screening, this is the Penacam's cataract pre-op display. We'll show you a blow-up of the bottom right part in a second. So here again, we can look at SIMK values on the upper left, total corneal refractive power in the middle, and at the right you will see it's the axis variation between SIMK values and total corneal refractive power. Regardless of which formula you use, I always determine axis by total corneal refractive power. And that's again because no matter what formula you use, what attempt they do to compensate for not measuring the posterior surface, they can't adjust for an axis change. And axis misalignment is more critical than magnitude, being often magnitude in most patients. And many of you have seen these numbers before, but a 10% loss of effect with only a 3-degree misalignment, a 33-degree loss with a 10-degree misalignment, a 50%, half a loss of effect with a 15-degree, and if you're more than 30 degrees off, you actually increase cylinder. So again, standard anterior base formulas, what I use, particularly this is if I'm using the original Alcon, in with the rule patients, I use the smaller of the SIMK or total corneal refractive power. With against the rule, again with the original Alcon formula, I used to use the larger of the SIMK or the total corneal refractive power, but I never do more than a half diopter above total corneal refractive power because I don't want to flip axis. I use the total corneal refractive power to determine suitability for a toric IOL candidate. Regardless axis determination, I use total corneal refractive power. So let's look at some of these. I'll flip through these real quickly. Here's a patient with high cylinder and axis match very, very well. I can't read the numbers, and I'm guessing you can't read the numbers from there either. Here's a very huge axis change, but a very low magnitude, so not clinically significant. Here you'll see clinically significant magnitude change, and I have to apologize because I can't see the numbers, but here you have about a half diopter difference. But the real key here is axis change. And I'm just going to flip to that because we're running out of time, but here's clinically significant axis change. If you can read the numbers, you'll see they match up fairly well here, but this is almost a 20-degree axis change, and this one's about an 11-degree axis change. So the magnitude matches up, but we're talking about 11 degrees in the lower example and 20 degrees in the upper example. Those are huge changes in magnitude in axis. So in summary, if you're using the original Alcon formula, and with the rule patients, I suggest the smaller of the two between SIMK and total corneal refractive power. Against the rule, I use the larger. If you're using the newer Barrett, which does a better job and not a perfect job, I just use the SIMK values. I use total corneal refractive power to determine suitability. I use total corneal refractive power to determine axis, regardless of which formula you use. But again, there are a number of formulas that you'll hear subsequent to my lecture that actually will use tomographic data. So I suggest the routine use of the cataract pre-op display, the routine use of the bad display as a screening to determine whether someone is suitable for a multifocal. And again, total corneal refractive power determines suitability, and total corneal refractive power for axis determination. And in general, all workup should include some type of IOL calculation. You hear more about the AXL, again, the cataract display, and the bad display, just to do a quick screening of your patients. So I'm glad to turn over the podium now to Dr. Conan, who will be talking about an overview of the Penacam AXL.